This individual, I would say, has demonstrated clearly resistance to hydroxyurea based on current European leukemia net criteria, but as well as some degree of intolerance. They would be a candidate for targeted therapy, and specifically ruxolitinib is indicated for individuals in this setting, and would be very consistent with the types of individuals recruited onto the clinical trials for ruxolitinib in hydroxyurea resistant or intolerant patients that then went on to ruxolitinib. Ruxolitinib has been very effective for patients with polycythemia vera, in particular individuals with the phenotype of this patient with problematic polycythemia vera. And that has a variety of manifestations. A good control of the hematocrit in those that have failed hydroxyurea by resolution of need for phlebotomy, by control of erythrocytosis. Improvements in splenomegaly when it has been present. Improvement in disease-associated symptoms, in particular difficult symptoms such as pruritus, night sweats, etc. It also has been demonstrated compared to best alternative therapy to have a significant impact on decreasing the risk of thrombosis or bleeding, which are, again, key goals for us as we're managing patients with polycythemia vera. Targeted therapy with JAK inhibition with ruxolitinib in patients with polycythemia vera seems to have a strong impact on decreasing the risk of thrombosis and bleeding. And we believe that that may be from a variety of factors. One, good control of myeloproliferation, a control of the counts which has been long recognized as a goal of therapy. We do believe that there may be some other positive benefits to this line of therapy in decreasing that risk. Ruxolitinib as a JAK1 and JAK2 inhibitor helps to decrease inflammation associated with polycythemia vera. That inflammatory state is probably conducive to the development of thrombosis and bleeding. That may be helpful as well. In addition, individuals are more active. They feel better. It's clearly been demonstrated that they're more active, they're walking around more, and again, that probably has an additional level of benefit in terms of decreasing that disease-associated morbidity from inactivity. The management of polycythemia vera has really evolved over the last several years. Throughout much of my career, we only had the options of phlebotomy, aspirin, and hydroxyurea. During these last several years, we have realized that with phlebotomy or cytoreduction, we need to be stricter than we used to be. Through the cyto-PV study, it was recognized we clearly have to keep the hematocrit under 45% to decrease that risk of thrombosis and bleeding. We've recognized the value of aspirin. In the past, aspirin was felt to be contraindicated. Maybe it increases the risk of hemorrhage. That was demonstrated that with low-dose aspirin, it's both beneficial and safe to use. And finally, we clearly have seen the strong benefit of JAK inhibition with ruxolitinib in this group of patients. Indeed, after the discovery of the JAK2 V617F mutation in patients with polycythemia vera, it was speculated even from that time in 2005 that if we had an inhibitor of JAK2, it would be very effective for polycythemia vera given the overrepresentation and overactivity of the JAK-STAT pathway in these patients. Polycythemia vera still has unmet needs. We still are trying to identify whether there's a role for targeted therapy earlier in the disease. Should it be used in the frontline setting? And there are efforts ongoing to try to identify whether that should be the case. We still are trying to figure out why is it that patients progress? Are there other ways that we can make that progression less likely to occur? We do recognize that individuals, even with sometimes effective targeted therapy, have improvement in their symptoms but not complete resolution. So our group has been very active in looking at non-pharmacologic complementary approaches to try to help these patients further, whether that's through physical activity, yoga, meditation, etc., but to manage some of the chronic symptoms they can have with a difficult disease. In polycythemia, there are many exciting things ongoing. In the arena of targeted therapy, I think the key question is, should we be using these therapies earlier, even in a select group of individuals, to try to have a greater likelihood of them not progressing into the future? There's also investigations going on with other agents, whether the nutlin inhibitors, interferons, or others, and whether single agent approaches or perhaps combination approaches that involve as well ruxolitinib as part of that therapy, I think are both very exciting and may lead us to deeper levels of control with the disease.